Good morning, everyone. I'm here to talk about intrinsic and extrinsic falls. My name is Amour Dondi. I'm a fourth-year graduate student, and I'm working under the supervision of Dr. Davis. So for the purpose of this study, we'll start defining the key terminologies. When we talk of falls, we adopted the definition from World Health Organization, WHO, which meant an event where a person comes into rest on the ground or a lower platform, and it's an unintentional and normally results into injuries most of the times. A rate of falls, this will be the frequency of falls occurring in a specific population over a specified period of time. It's normally expressed, for instance, falls per 1,000 person days or 1,000 person years. Home health care centers will be facilities that provide healthcare services to the patient at their homes. If you take out the word health and becomes home care, this will be the non-medical services, but still at the home of the patient. And long-term care facilities, this will be those health care services being done to a patient in the respective facility and not at their homes. And the adults we looked at were the elderly, starting from the age of 60 and above. So going back to the literature and background, falls remain a challenge in the healthcare community, whereby it's been reported there's been a quite number of non-fatal injuries due to falls for the patients, particularly the fraction of the elderly patient 65 years and above. And the mortality rate continues to increase. Over the past years, it has gone up to 30%. And again, it is this age group of 65 plus that kept on having a high rate of falls. Economically, there's a financial burden due to falls, which has resulted to direct cost of around 159 million. This was back in the year 2000. This in all could have been updated, but also the total direct costs attributed by falls resulted to 19 billion in the healthcare sector. Now, when we look at falls, they're into three groups. We have those accidental falls, and we have those called anticipated physiological falls and unanticipated physiological falls. The anticipated physiological falls are due to aging, ailments, or medications. This will be your intrinsic factors, internal factors. The unanticipated physiological falls are those that are just due to various physiological reasons. And most of the accidental falls would be due to environmental factors or operation issues. And this will be the extrinsic conditions surrounding environment where the person fell. So for the purpose of this study, we'll be considering the physiological attributed falls, which are then divided into two categories: the intrinsic, which will be the factors that relate to the existing physical fitness. The intrinsic factors are those, the physical fitness of the patient that can exacerbate the person to fall. Some of those will be, for instance, the lower extremity weakness, fear of falling, the gait or balance deficits, vision impairment, urinary incontinence, and stuff like that. Extrinsic factors will be due to the environmental conditions, as I've said, maybe lack of grab bars and somebody fell, housekeeping conditions, sleep, trips and falls, height of bed or chairs, the lack of using the assistive devices, poor conditions of the floor, and all this kind of stuff. So these are the two main factors that cause falls. Now, what does all this information, so what does it mean? In the first instance, we believe that healthcare patient safety goes hand in hand with the healthcare workers' safety. If we are able to control this burden of falls, the effect of falls, because the natural reaction of a healthcare worker when a patient falls is to quickly assist them. And there's been evidences that there are some work-related injuries faced by healthcare workers when they assist patient falling. So we're trying to counteract these causes so that we can then create a safe work environment for the healthcare workers. Why is that? Because home healthcare remains the fastest growing industry in the US, so we'll see this increasing. And also the elderly population is expected to increase significantly in the long-term care facilities, up to 3 million. This calls then for annotation. Therefore, healthcare workers are exposed to significant risks such as the low back pain, due to rescuing or assisting patients from falls. That's why we want to study the falls, understand the causes, and then see how we can support the healthcare workers. So the objective was to identify intrinsic and extrinsic factors that contribute to patient falls and the subsequent burden to caregivers. And the first hypothesis was, patients in the home care environment are exposed to significant extrinsic and intrinsic fall factors as compared to the patients in the long-term care facilities. And then our second hypothesis was nurse aides experience significantly higher postural demands and falls burden index compared to nurses in both long-term care and home care settings. So the first specific aim was to go in the field and to kind of evaluate the existing condition, the status quo with regard to these 4 risk factors in both long-term care and home care. And then our second objective, which is still ongoing, is to objectively quantify the postural demand experienced by nurses and nurse aide in long-term care facilities in home health care settings. This is by using the sensors, and I'll talk about it. So the methods, the recruitment, basically we sent out flyers and emails. We did in-person visits and walk-ins to try and recruit participants to present our study, try to recruit different patients who could take part in our study. The inclusion criteria, we were looking at men and women aged 60 and above, must have stayed in the healthcare setting for a period of 2 weeks and above, must have no fractures of lower extremities or the torso, no major surgeries in the last year, and able to read and understand English. So this is a picture where I went to the healthcare facility and I presented the study during an event there. They gave me an opportunity to talk about what was going to do. It was really good because this was what led to many participants signing up for the study. And then the equipment used, we needed an armless wooden chair, measuring tape, stopwatch, pens, and clipboards. This was supposed to correct different information. And the assessment tools we worked with, the first was the demographic questionnaire, which had basic information around age, gender. And also this is where we had to understand if there was any vision problems, if they had experienced falls in the last year, if they had chronic health conditions, and all that was captured in our demographic questionnaire. Another one we worked was the falls efficacy scale. This is a questionnaire that's out there to understand the fear of falling, because fear of falling is one of the reading factors that can cause a patient to fall. So it had items that were capturing when a person is reaching into cabinets, when a person is walking around the house and doing different tasks. What is their fear of falling in a scale of 1 to 10, 1 being very confident and 10 not confident at all. Fear of falling is that negative effect, causes those negative effects of a person thinking or being scared of falling. They will eventually have a likelihood of actually falling. Then we did the timed up and go test. This just helped to evaluate person's mobility, balance, walking ability, and the risk of falling. So we had a chair and made a 3-meter distance walk for the participant, and we timed up the time when they did that going and coming back. And then we did the CATS index of independence in activities of daily living. We captured these different items, how independent the participant were in taking a shower and cooking if they did, and all that. And then we administered the mini mental state examination questionnaire, which is intended to understand the cognitive ability of the participant. We did the hip and knee function test, the TNET balance assessment tool, which was looking at the balance and gait, as well as the strength and mass of the limbs, because these are the intrinsic risk factors which can result in the patient falling. The extrinsic risk, this was assessment of the home environment. We used the West-made home safety assessment tool to kind of understand opportunities for slip, trips, and falls, and bed height and stuff like that. So data collection procedures, the participant, once interested, they completed the informed consent. Demographic survey was administered, and then we administered the assessment tools following the standard operating procedures we had laid out. And then at the end of the study, an incentive was provided as a way of saying thank you to the participant. All right. In terms of the National Occupational Research Agenda for Healthcare and Social Assistance, we believe this study falls in because patient safety and caregiver safety goes hand in hand. So we kind of came from the angle where the council concentrates on occupational risks faced by healthcare and social assistance in hospitals, nursing homes, and home care. So this was looking at the postural demand of a caregiver when they assist a patient falling. For that, we had to understand the existing factors of risk factors for patient falling and what does that mean to the caregiver. And then, so when we went out in the field, we collected 28 participants already. This is still ongoing. The target is 45. We're still going out in the field collecting data. Not 16, but 15 participants resided in independent living senior residential homes at Springdale, and 13 participants resided in a long-term care facility at Blue Ash, Ohio. And all of them reported a total number of 24 falls in the last year. They experienced 24 falls in the last year. So you can see we still have a problem with patient falling, elderly falling in these healthcare settings. We're still going out in the field, collecting the data, but preliminary analysis, these are the study characteristics, participant characteristics. You can see that we had more males than females already collected, and most of them experienced 50% of the study participant experienced falls in the last year, as you can see on this slide. And we looked at the type of healthcare setting. This was home healthcare and long-term care. And in terms of race, we had more people in white than the black, and also all participants had chronic health conditions. They had balance disorder, they had vision problems, and they were using medication, and they had difficulty in walking or standing, which are all intrinsic risk factors that can result in a patient falling. So looking at the age, most of the participants were at the age of 60 and above. I had two that were below 60, but they were really interested in taking part in the study, and they wanted to understand what was going on. I just had to include them. And then looking right now, this is preliminary data analysis. We're still going out in the field, but most of the participants had that fear of falling. The score was really way high, showing that then this is a risk factor for them to fall. And the CATS index total score, most participants as well were not independent. Most of them needed help in different capacity. Looking at the mini mental state examination, this was interesting. The cognitive ability for almost all participants was really good. There was no much cognitive impairment that I can really talk about. And then in terms of the timed up go test, most participants struggled with this, and I lost quite a few participants during this exercise because they could not keep up with it, showing that the mobility was still under discussion. And then in terms of the balance and the gait score were both very high, showing that participants struggled with balance, maintaining the center of gravity portion during standing, and they swayed a bit in the tests we administered. And then the hip and knee function tests, we had a couple of participants reporting pains during bed rest and pains during standing and walking, showing that this was also a risk factor for patient falls. So now we've identified that patient falls remain a challenge. Like I said, we're still going out in the field identifying these falls. But what does these findings mean for a caregiver? So we still that we have a problem patient falls. So this took us back to the field again, and we're now doing the objective quantification of postures experienced by healthcare worker in the long term. This is now a study going on. We're working at a healthcare facility in Norwood, where we are using MTN Xsense, 17 sensors being put on the lower and upper extremity of the caregiver, the nurses. It's a motion capture system that will give us the objective, the postural demand in terms of the acceleration, the angular velocity, the linear acceleration, and the timestamp of the nurse or the nurse aide when they're assisting the patient. We are also administering care falls burden index to the nurses to understand the burden they face when helping a patient who is falling. What is the worry they have when a patient is falling? What is that extra time they spend to help and manage falls? What are the physical injuries that they experienced in helping a patient who has fallen? So with this portion, we've collected already six participants, six healthcare workers, and this is also ongoing to kind of show the relationship between patient safety and caregiver safety. So you can see in this picture, these are the sensors that we do provide, we put on the participant, and we try to follow them from the first 4 hours of their shift when they're helping a patient to objectively quantify that. So in conclusion, research practice, we are trying to integrate wearable sensors technology into routine occupational health and economic assessment to get the real world data, the objective quantification, and not the subjective one. Future potential work, this can be employed in longitudinal studies, conducting long-term monitoring on how to assessing how posture-related risks evolve over time and how interventions can impact the musculoskeletal health. One could also do predictive modeling using wearing technology to develop and validate patients at high risk of falling proactively. So these are two concepts. You can utilize it in the patient safety world, which will then positively impact the healthcare safety. Overall impact, we believe this study provided a positive impact in both patient and caregiver safety, which is of paramount importance in the healthcare industry. In saying thank you, we acknowledge NIOSH for the support, and also really thank you to our supervisor, Dr. Davis, and Dixon, Mercy, and Robbie, who have been part of the team and helping out in data collection. And also very much thank you to long-term care and home health care management, who have been very supportive. These are the references, and we expect 2 publications. One will be talking about the findings from patient safety. Another publication will be looking at the postural demand from the healthcare workers. And we expect to present these findings in various conferences, such as the Human Factors and Economic Society Conference, AHA, and ERC Symposium next year probably will come with very good results for them as well. I'll be able to take it.
Great, thank you. Great. Do we have any questions for Amour before we break? And he will be around, but this is part of an ongoing study of various aspects. And thank you so much for presenting this one. Please ask him questions. And in the meantime, we're going to break now.